Now, let's see, it is 10:05 my time, and we'll now reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All of the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important each speaker limits his or her remarks to 3 minutes. There will be a timer displayed on the screen, so you'll know how much time you have left. And I just want to thank our speakers again, and we look forward to your comments. So our first public commenter for today is Ms. Hannah Kaufman. Ms. Kaufman, please go ahead.
Hello, my name is Hannah Kaufman, and I am immunocompromised. I live with ankylosing spondylitis and Behçet's disease. I currently take 3 different immunosuppressant medications, including an antimetabolite, a biologic, and corticosteroids. I was hospitalized twice in June for a bad flare of my autoimmune disease triggered by a relatively mild non-COVID infection, and I am speaking to you today from the infusion center where I am currently being treated with Remicade. My doctors are waiting on clearer guidance from you before they can recommend moving forward with any kind of third vaccine dose recommendations for me. My plea is that the guidance you come up with and vote on today defines immunocompromised as broadly as possible. I implore you to leave as much to the discretion of patients and healthcare providers working collaboratively to determine individual risk-benefit of third doses on a case-by-case basis. I want to stress the importance of recommending third doses for people in all categories of immunocompromise and immunosuppression. It is terrifying to know that vaccinated solid organ transplant recipients are 485 times more likely to be hospitalized or die than their healthy vaccinated peers. Still, many of us don't know our risk level. I haven't had a transplant. Am I 300 times more likely to die? Am I only twice as likely to die, which is still horrifying? What is the threshold where I should get a third dose? Quite honestly, death is not the only thing I fear, and not even the thing I fear most. What truly scares me is the possibility of developing long-term COVID complications that will further degrade my quality of life, something I don't even know the likelihood of because we aren't keeping track of it. I need to do all I can to avoid infection in the first place. The world has become much less safe for people like me since people took their masks off in May. I was unable to even pick up my immunosuppressant medication from the pharmacy yesterday because there were unmasked people bumping into me from all sides in a zip code that is only 39% vaccinated. For immunocompromised people with less effective vaccinations, the recommendation has been to build a shield around us of others who are vaccinated and others who are masked. These are wonderful aspirations, but not at all in our personal control. Please give all of us who are immunocompromised a fighting chance to protect ourselves in a world where we have to rely on others to make the right choices, and many refuse to do so. Please keep the interpretation of immunocompromised as broad as possible. Don't just do it for people like me. Do it for the caregivers who are exposed to us. Do it for the children we live with who are too young to be vaccinated and are being thrown back into schools without masks. Do it for the population as a whole. I don't want to be the one who incubates the next variant of concern. Thank you.
Thank you very much for your comments. Next, we have Ms. Elizabeth Fashing.
Hello. My name is Elizabeth Fashing. I'm from Erie, Colorado, and I am proud to be the Executive Director of Colorado Immunization Advocates. Today, though, I'm speaking as a parent with 2 children who are not old enough to receive a COVID vaccination and to urge the approval of the vaccine for those under 12 as quickly as possible. When my children were infants and too young to receive all of the standard childhood immunizations, I felt some trepidation. I knew there were some members of our community who chose not to vaccinate their children and thus put my children at risk. But I at least had a light at the end of the tunnel. I knew exactly when each of my children would be fully vaccinated, and once they were, I could breathe a sigh of relief. Today, that trepidation is much different. There is no light at the end of the tunnel. I have no idea when my children will be able to get vaccinated against COVID. Instead of the highly localized outbreaks of vaccine-preventable diseases that were easier to avoid a few years ago, COVID is everywhere, and my options to protect my kids from it are limited. They don't come to the store with me. We haven't traveled with them on airplanes or visited the public spaces we used to enjoy, like the museum. My husband and I got vaccinated as soon as we could. We wear masks everywhere. Next week, my kids go back to school. I am more worried this year than last year because of the contagiousness of the Delta variant and the number of children currently infected and hospitalized. Although we are fortunate to live in a county which has mandated masking for all students and staff in schools, I still know that the best way to protect my children is to get them vaccinated. Other friends live in districts which don't have mask mandates. Some of my friends have children who are immune compromised. Only one district in our state is requiring teachers and staff to be vaccinated. We need to get our kids access to the vaccine. Please, on behalf of all parents who are facing such an uncertain school year and who want to do everything we can to protect our children from COVID, please approve the COVID vaccine for children as soon as possible. Thank you.
Thank you very much for your comments. We'll move on to Ms. Elizabeth Ann Ditz. Ms. Dietz, are you on the line?
She is on the line, Dr. Lee. She may be having problems with her audio.
Okay, thank you. What we can do is we can move ahead to, and we'll come back to Ms. Dietz. Ms. Heather Brayton.
Can you hear me?
Yes, we can. Thank you.
Thank you for allowing me to speak today. I wrote different versions of my public comments because I did not know which groups you would qualify for additional vaccine doses. It seems that this is still being clarified, but that I will most likely qualify. I am a 44-year-old ovarian cancer survivor. Although I was grateful to receive my Pfizer vaccination this winter between cycles of chemotherapy, I was also worried because I knew chemotherapy blunts the effects of vaccines. I regretted that I could not wait until after treatment to get my shot. Over the past few months, I have become somewhat obsessive with reading news articles and medical studies. I have become so anxious because research showed that cancer patients like myself who have solid tumors only develop a fraction of the antibody titers, T cells, and B cells as healthy controls. I have felt distraught over the situation. My prognosis is poor. I most likely have about 2 to 3 years left to live, so every day counts. My life ambitions are humble. I want to be able to visit with vaccinated friends and family and not have to worry that I'll become a breakthrough case just because we took off our masks or got too close to each other or dared to actually spend some time inside. I'd like to go grocery shopping again and not panic and leave the store after 5 minutes. I'd love to travel because that's what people with a diagnosis like mine usually do before our health deteriorates. But the fear of catching COVID and knowing that I could become seriously ill and that approximately 10 to 30% of cases become COVID long haulers has kept me from being so bold. I don't think I could cope with both the side effects of cancer treatment and debilitating post-COVID symptoms. I'd like to thank the committee for including cancer patients like myself who have recently undergone chemotherapy for solid tumors to potentially receive additional doses of COVID vaccines. I'm not afraid of potential side effects of the third dose. While I understand I will still need to be cautious, I am hopeful for the peace of mind and greater freedom a third shot can provide. Thank you for listening.
Thank you very much for sharing your story. I'll see if Ms. Elizabeth Ann Ditz is on.
I am.
Thank you. Please go ahead.
Good morning. My name is Liz Dietz. Greetings, committee members and work group members. I am grateful for your tireless work over the last 18 months and in the time before COVID-19. Who am I? I have been advocating for high vaccine uptake in my community in San Mateo County for over 20 years. I'm a founding member of Vaccinate California, a grassroots volunteer advocacy group. I'm a longtime supporter of Voices for Vaccines, a national parent-led organization advocating for vaccine uptake. I'm a frequent contributor to a Facebook group called Vaccine Talk, an evidence-based discussion forum which has over 67,000 members worldwide. Over the last 4+ years, this group has helped 443 people move from being vaccine resistant to vaccine accepting. That's about one every 3.5 days. So fact-based social media is having a positive impact. I'm also over 65 with several risk factors for severe COVID if infected. I have been fully vaccinated for 153 days. Eventually, I might be in a group considered for a booster dose. I want to make 3 points. 1, over-reliance on vaccines as a way to end this pandemic. 2, global perspective on vaccine access. And 3, health equity in the US. First, I know you are all not the Advisory Committee on Non-Pharmaceutical Interventions for COVID prevention, but I must say that the US's hyper-focus on immunization over NPIs has harmed our country's response to this crisis. As a nation, we must adopt all the tools at hand to tame this virus. Second, Gavin Yamey, MD, tweeted, "For the love of all that is good and holy, we need to recognize that we are a global community. There's a moral and ethical urgency to ensure that everyone worldwide has the same chance to benefit from the fruits of scientific progress, not just rich people." Finally, here in San Mateo County, we have a very high vaccination rate with noticeable holes. Many of our agricultural and hospitality industry workers are not yet vaccinated. But one friend learned she was bringing in vaccine advocates who were native Spanish speakers. It turns out most of her employees, although from Mexico or Central American nations, were not native Spanish speakers and didn't really have health vocabulary in Spanish. They were native Nahuatl or Mixtec or other indigenous languages without health vocabulary in Spanish. So we need to fine-tune our efforts to increase vaccine uptake. Thank you very much.
Thank you very much for your comments. Ms. Pam Dixon.
Yes, thank you. Chair Lee and members of the committee, thank you for the opportunity to participate in the ACIP meeting today. I'm Pam Dixon, Executive Director of the World Privacy Forum, a public interest research group focused on privacy and data governance, including in the health sector. I have 2 brief points today. First, we support the CDC's prohibition on the use of vaccine recipient data for commercial marketing purposes. The CDC's vaccination program provider requirements, published in May of this year, specifically prohibits the commercial marketing use of COVID-19 vaccination registration information and the vaccine administration data. These prohibitions were warranted and are important for ensuring patient trust in the public health data ecosystem. I note that standard HIPAA rules already prohibit providers from using patient data for commercial purposes. There is now, after many years of HIPAA implementation, a reasonable expectation of some of the same levels of privacy in COVID-19 data ecosystems. Very few individuals understand the labyrinthine rules regarding HIPAA-covered ecosystems. Oh dear, HIPAA-covered ecosystems, and I'm sorry, I'm getting an emergency heat alert. Anyhow, let me get back on track. Very few individuals understand the rules regarding HIPAA-covered ecosystems and public health ecosystems. And then second, we urge the committee to ensure that the same prohibitions that have already been put in place for commercial marketing uses of vaccine recipient data will also be required when the data is utilized in vaccine credentialing systems or proof of vaccination systems. We see significant potential risks for the commercial use of patient registration and patient vaccination data due to the sheer number of credentialing systems in development across complex public-private pathways. In conclusion, we support the work that the ACIP committee is doing to protect privacy interests and the integrity of public health data. We can all say a lot about how credential systems should operate, but this committee has the ability to make the most important statement of all about this ecosystem, which is to ensure that the data of those who have been vaccinated is fully protected in credentialing systems as well. Thank you very much for the opportunity to participate today. And my apologies for our emergency heat alert in Portland, Oregon. Thank you.
Thank you very much for your comments, and it's not a problem. We'll move on to our last public comment speaker, Mr. Edward Nirenberg.
Hello, and thank you for this time today. I'd like to call attention to several issues. To begin with, I do think it's important to offer consideration to heterologous boosting strategies. Immunogenicity data suggests superior responses from the combination of adenovirus vectors and mRNA vaccines, and preliminary effectiveness data suggests non-inferiority. Given, however, that the Sasanki study has just found 71% effectiveness of the Janssen vaccine against hospitalization, I would request that mRNA boosters be offered for recipients of Janssen, a vaccine that may have been favored in the first place by more vulnerable groups for whom access to vaccination may be an issue. Additionally, immunocompromised patients' infections are especially concerning for their public health implications because of the propensity for antibody escape variants of SARS-CoV-2. It may be worthwhile to consider prophylactic dosing of monoclonal antibody cocktails for those who have substantial humoral immunodeficiencies. Pregnancy is also an important high-risk state for COVID-19, and given that some individuals are becoming pregnant relatively far from their initial immunization, it may be worth considering additional doses during pregnancy both to bolster their protection and to provide passive immunity to their future children through transplacental neutralizing antibodies. I also think it's critical to remind everyone that we have a pretty grave situation with COVID-19 in the pediatric world. Since the beginning of the pandemic, in spite of aggressive mitigation measures in the U.S., approximately 500 children have died, tens to hundreds of thousands have been hospitalized, millions have been infected, and hundreds of thousands are additionally likely suffering from PASC. Furthermore, as was mentioned during the meeting, the AAP describes in a recent letter to the FDA that there's been a substantial rise in hospitalization among children recently, and I would urge everyone listening to do everything in their power to vaccinate their children against COVID-19 as quickly as possible. The call for a larger sample size by the FDA in clinical trials of children offers only marginal gains in the way of our pharmacovigilance, as sensitivity to detect rare adverse events, even with this change, would remain limited. But access to vaccination would be substantially delayed, and this is in the midst of a significant surge. The late sequelae of COVID-19 in children are presently unknowable. Measles causes SSPE only months to years after initial infection. Its complication is both fatal and lacks treatment options. If COVID-19 causes anything analogous, we will not know for some time. A circumspect approach should dominate here, given the substantial costs incurred from threats to child safety and well-being at the public health scale. Lastly, I would request more frequent updates from VSafe and the Vaccine Safety Data Link if possible, as I think that having these references of vaccine safety for the public is extremely valuable. I would additionally like for stronger language regarding the recommendation to vaccinate recovered patients now that the clinical benefits of doing so have been ascertained in addition to the immunological ones. Thank you very much.
Thank you very much for your comments. And with that, our public comment session has ended, and I would like us to move on to the vote and discussion on the topic of additional doses of mRNA COVID-19 vaccines as part of a primary series. Dr. Dooling, would you be willing to put up the proposed language for the recommendation?
Yes, thank you, Dr. Lee. So to revisit the policy question that's in front of ACIP, should vaccination with an additional dose of Pfizer-BioNTech COVID vaccine in those 12 and older, or Moderna COVID-19 vaccine in those 18 years of age and older, be recommended following a primary series in immunocompromised people under an emergency use authorization? Next slide. And to recap, the work group determinations were that the desirable consequences clearly outweighed undesirable consequences in most settings, and they supported we recommend the intervention recommendation. Next slide. So the vote language here in front of you is that an additional dose of Pfizer-BioNTech COVID-19 vaccine for those 12 and older, or Moderna COVID-19 vaccine for those 18 years of age and older, is recommended following a primary series in immunocompromised people. Thank you. I'll turn it back over to you, Dr. Lee.
Thank you. I will break this up into two sections. I would request that that any of our voting members can make a motion on this interim recommendation, and then we will move to a discussion around this. So if there's any clarifications that are needed from ACIP members on the wording of this, please chime in now, but otherwise I'd like to move forward with a motion. Dr. Chen?
Forgive me if this is already known within the work group, but I believe that Moderna did submit to the FDA for the adolescent indication in June, and I don't know if there is a projected timeline for when that determination may be made by the FDA, but I just wonder if this language that we have presently for Moderna and the 18 years will need to be then quickly revised in response to that potential EUA authorization extension for the Moderna product. And so if it's expected to be soon, then would we have the ability to have flexibility in this language to really suggest for the ages that it is authorized rather than those specific ages, or is that not allowable? Because again, we are only able to make the recommendation on present EUA authorization. Well, in there.
This is Dr. Dooling. I think the intent today is to proceed with the maximum specificity we can under the emergency use authorizations as they stand today. If there are additional products or expanded EUA in the future, we will certainly come back to the ACIP with any modifications at that time.
Thank you for the question and the clarification. Dr. Alt?
I move that we accept the language on the slide for a vote.
Thank you, Dr. Alt. Dr. Paling?
So, Dr. Lee, that was the motion. So, are you looking for a second?
I'm sorry. I found my unmute button. I was seconding that motion, please.
Thank you. Okay, terrific. So it's moved and seconded that we adopt the recommendation language presented by the work group here on this slide. Before we move to a vote, I'll invite our voting members to discuss the motion on the table and ask if there's any additional questions or issues the committee would like to discuss before the vote. I see Dr. Alt's hand is up. Go ahead.
Well, I actually had the same question that Dr. Chen did. I just wanted to make the motion first. So what's the mechanism for us coming back and rewording this? Will we have to have another meeting, or that just happen automatically specific to the Moderna vaccine?
So, Dr. Alt, this is Amanda. To clarify, so as soon as if and when there is FDA authorizes the Moderna vaccine down to a different age group, we will have a meeting to review that data and to vote both for all kids down to that age group to be able to receive Moderna, and we will revise this at that time. We don't yet have a timeline for that, but under the EUA, we're wanting to make sure we're very careful to vote for each change, even if just to make sure that we're recommending things under the EUA. So yeah, we'll come back as soon as that Moderna EUA is authorized.
That makes perfect sense. Thank you.
Thank you. Ms. Bachma?
Thank you, Dr. Lee. I just wanted to weigh in here that I am really grateful that we finally have an expanded EUA, particularly for the immunocompromised, so that we can provide more protection for those who may not have responded initially. And I really think that this is overdue, but we're working as fast as we can. I do acknowledge that. And also wanted to urge clear communication about who this for, why it's an additional dose, not a booster dose, because those kinds of things are already in the general public arena as a very confused concept. Thank you.
Thank you. Would any other ACIP members like to comment on this particular motion that's on the table? Oh, Ms. McNally, please go ahead.
Thank you. Dr. Lee or someone at the CDC, can you confirm for me that the information for the public will be clear regarding the mRNA distinction versus the J&J vaccine as not being an eligible option? Thank you.
Yes, this is Amanda. So the language in the clinical considerations, which I know is meant for providers, indicates that at this time there are no data to support use of an additional dose of mRNA vaccine after the J&J vaccine, but we are working as fast as we can, and we anticipate that we will soon have data that will help support that or be able to offer that. All of these recommendations, and thanks, Ms. McNally, for bringing this up because we've talked about this a lot. We will have a communications package for both healthcare providers and the public to make sure that people understand both if they're in this group, who needs booster doses or additional doses, and who doesn't. And we are working on those materials and will adapt them according to the discussions today. But there will be both provider materials and materials for the public, similar to what we've done with some of the recent warnings. Thank you.
Thank you. And I just want to highlight how incredible the CDC staff have been in really putting together these education and communication materials, which is an incredible challenge under changing context, changing data, evolving data. And so, just kudos for doing a phenomenal job. We recognize it's not easy, and the demands on your team have been tremendous during this COVID-19 pandemic in many directions. So, but we appreciate that you continue to prioritize communication as a key component of what we need to do to implement our recommendations. I'll turn it over to Dr. Cotton.
Thanks. I would definitely like to second that with all the hard work done by the CDC and really following the science and, being adaptable to things as they evolved. And all of us are very appreciative of that for sure, especially from CDC and other FDA leadership, et cetera. I just have a nuts and bolts question. So I am getting a tremendous amount of messaging across the board from patients and leadership in my own healthcare system. It seems like as soon as this meeting ends, there may be many people that go ahead and go get themselves vaccinated at a variety of places. Is there anything further that you will be, you'll provide us guidance? Do we have any idea for time frame? It's kind of just really the nuts and bolts of this rollout, because I'm sort of suspicious that many people who are more than a month out from their second dose of vaccine will be going out this weekend to get themselves another dose. Just wondering if there's anything more, any guidance.
Thanks, Dr. Cotton. Yeah, we will have, we are working as we speak to update the clinical guidance based on the feedback and input that you provided. And we anticipate, if this vote passes, that we will publish that updated clinical guidance sometime late afternoon or evening. We're also having partner calls that we will share this information with today. We anticipate having a COCA call early next week, and we have been working, over the last 24 hours, maybe 48, with pharmacy groups and with our jurisdictions to prepare for implementation of this recommendation. So we're hopeful that this will be rapidly implemented.
Thank you. Can I just ask you, when they go to a pharmacy, are people going to be asked, screened in any way, or is it kind of an anticipated honor code approach?
So it's typically when somebody goes to a pharmacy, there's typically several questions that they ask to make sure they don't have any contraindications. And I can't speak on behalf of the pharmacy groups, but they may manage this differently, but they'll likely just say, do you have a moderate or severe immunocompromising condition or something like that? But it will be a patient's attestation. And there will be no requirement for proof or prescription or a recommendation from an individual's healthcare provider.
Thank you very much.
Thank you. I do not see any additional ACIP member hands raised. Oh, I do. Dr. Sanchez, go ahead.
Sorry. Thank you. I just didn't realize I had taken it down. A couple things. First of all, I just want to, will Be Safe be amended to include that this is a third dose? I'm not sure if that was discussed, or because obviously we really want enhanced surveillance. So I don't know what if Be Safe there is already an option or not for multiple doses. So that's my first question. And then I just really think that we do need to provide some guidance. I know that we don't have the data on those individuals who received the Janssen product and then followed by messenger RNA, but that I'm sure will, I think CDC must comment on this, because similar to the fact that already people have received the third dose, immunocompromised individuals have received third doses even before this meeting. I really feel that we need to comment on a messenger RNA vaccine after the Janssen project, because it's happening, and personally, I am in favor of that happening as well. Thank you.
Thanks, Dr. Sanchez. This is Amanda. So absolutely, VSafe is being updated. I don't know if anybody from the Immunization Safety Office can provide us with an update of when that third dose is. Dr. Broder, can you give us an update on?
Sure. This is Karen Broder from the Immunization Safety Office, and VSafe is being updated to be able to capture information about dose 3 for both new registrants as well as those who previously have entered doses. Those updates are in testing now with a goal of trying to launch this weekend or no later than early next week, and information will be available on the web as well. And thank you for using VSafe, and thank you for the question.
Thanks, Dr. Broder. In response to your second comment, Dr. Sanchez, thank you. I mean, we totally agree. There's actually are studies that are being done with the J&J vaccine and then an mRNA vaccine, and we anticipate having some data from that very, very shortly. So we do think that this is going to be a very short-lived, we're hoping for it to be a very short-lived challenging issue, but we will work as hard as we can to be able to address this adequately and appropriately. But we do understand that it's happening.
Thank you. I see 2 more hands raised, and then hopefully we can move on to vote unless there are any other questions or comments that our ACIP members would like to make. Ms. Stinchfield?
Yes, thank you so much, Dr. Lee, and all the presenters today. I support the vote as noted here. As clinicians and health systems, what we will do from here is turn to our electronic health records and try to poll the patients who meet this requirement and communicate with them directly. And so as specific and clear as you can be in the clinical guidance, things that we can pull, coded diagnosis, specific drugs, medication names, et cetera, that will be very helpful to a tired group of clinicians out in the field. Immunosuppressive therapies and severe primary immune deficiencies are too broad of terms to be useful in an EHR. So thank you for that consideration.
Thank you. And Dr. Shaw?
Thanks, Dr. Lee. Just a few observations. The first, and this is very much in keeping with Ms. Stinchfield's comments. I note that the FDA's EUA expanded the ambit of the mRNA vaccines for those who have undergone solid organ transplantation or who have been diagnosed with conditions that are considered to have an equivalent level of immunocompromise. Even in the discussion today, what's been discussed is moderate to severe, but the motion on the table is is a broader swath of what appears to be all immunocompromised. And so I'll defer to you as the chair about whether there's wisdom in amending the language to reflect following a primary series in those who have moderate or severe immunocompromise or something of that nature. Otherwise, some of the concerns that many commenters have noted around patients knowing whether they are eligible, they may read the EUA and find themselves to be ineligible because of the higher bar, but then read the motion on the table from ACIP and think that they are eligible, and that would create a fair degree of confusion. So that's one observation and potential avenue there. Two others, or three others, very quickly. I can imagine questions arising about whether there is a date beyond which the additional dose would not have immunological efficacy. So I know that it's at least 28 days, but as has been noted, many individuals in this category would have been vaccinated 5, 6 months ago. And there may be questions about whether if I finish my dose series 120 or 180 days before now, will this third dose get me where I need to be, or should I repeat the entire series? I know that's not under discussion right now, but it could be something for inclusion in the clinical criteria. Similarly, in the discussion that's published, there will be some interesting questions that states will have to grapple with. From a regulatory perspective, for example, are the 2.7% of the population that would be subject to this, are they no longer considered fully vaccinated until they get this third dose? That has an implication down the road. Similarly, if someone who is within that 28 days, if they get COVID, are they a breakthrough case now? So on and so forth. Those are some downstream considerations that states have already been talking about and thinking through that I wanted to offer. Thank you.
Thank you for the pragmatic real-world questions we have to face. I'm going to actually ask Ms. Coyle to state her comment, and then I'll ask our Dr. Dooling if she can respond to the collective comments.
Great, thank you. This is Rebecca Coyle, and I'm with the American Immunization Registry Association. And I think one thing I just want to sort of point out here is that we're sort of dipping into a new concept that really hasn't, I think, emerged before, and that's the idea of adding to a primary series. And while I think that's fine from a clinical perspective, I do think it's important to recognize the technology component of this, and particularly the clinical decision support capabilities of, I think, both EHRs and immunization registries. So one, on the immunization registry side, I think it's going to be important to note that immunocompromised is a very broad category, and most IS are not going to have the ability to identify individuals that would fall within this category because of the types of risk factors. And this will really be, I think, where EHRs and IS really have to work together there. And then I think the other important piece is whether a series is determined as complete. A lot of EHRs and IS will indicate that, following the primary series that it's complete and may recommend a booster dose. As we start getting into considering booster doses, when you now have a series complete at either 2 doses or 3 doses, how the booster doses may be reflected is going to be challenging, I think, for all systems. So just a couple comments, I think, to file away. Thank you.
Thank you for your comments. And I'll ask if Dr. Dooling or another colleague from the CDC would like to just add any comments or clarification to the discussion.
Hi there. Thanks, Dr. Lee. So to respond to a couple of those points that were raised, this recommendation is for moderately and severely immunocompromised people, which is very clearly spelled out with specific reference to conditions that would constitute that category in the clinical considerations document that will be posted on the CDC website. Again, our intention is as soon after the vote as is humanly possible. I fully support all of the statements that were made about registries' ability to collect a third dose. That is certainly in place, and agree that the more that we can link electronic medical records to add that specificity around immunocompromise, we should definitely be working towards that. So that I'll turn it back to you, Dr. Lee.
Thank you. Yes, and I personally, my opinion, I concur that I think it makes sense. Just similar to what we've done before, we provide a lot of clarity in what the intent of the recommendation is, but that adding too much specificity to the recommendation can be challenging. And I think the immunocompromised population is a special population that in and of itself, defining that cleanly is challenging. So allowing clinicians to be able to weigh in on that, I think, is really important for that individual benefit risk discussion. Dr. Sanchez?
Thank you. And actually, the previous person brings up an important point, because as we're seeing vaccine mandates, both at the, at all levels of society. Are we going to be considering immunocompromised individuals as requiring 3 doses, or is a 2-dose series sufficient to say that they are vaccinated? I think some clarification of that will be important as well.
Hi, this is Dr. Dooling again, if I can respond to that, a really important point. For the purposes of meeting the definition of fully vaccinated, it is 2 doses of mRNA vaccine or 1 dose of Janssen. That has not changed, and that will also be very explicitly spelled out in the clinical considerations.
Thank you.
Thank you. I do not see any additional hands that are raised, so I will assume that the committee is ready for a vote on the motion. Are there any objections to proceeding with the vote?
No, I think you can proceed with the vote, Dr. Lee.
Okay, terrific.
So we're going to ask, thanks, Dr. Alt, for everyone to put their video on to prepare for the vote. And once again, I know a lot of you have expressed your opinions. So if you do have a brief comment after the vote you'd like to make, that's great. But let's go through the vote first. And Dr. Lee, do you have the list of members to call out?
I do. So ACIP members, I'll ask you to state your name, whether you have a conflict of interest, and then your vote on the proposed interim recommendation that is shown on the screen there. We'll start with Dr. Long.
Sarah Long, no conflict, yes.
Ms. McNally.
McNally, no conflicts, yes.
Dr. Paling.
Paling, no conflict, yes.
Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Dr. Talbot.
Yep, Talbot, no conflict, yes.
Dr. Alt.
Alt, no conflicts, yes.
Ms. Bata.
Bata, no conflicts, yes.
Dr. Chen.
Chen, no conflicts, yes.
Dr. Daly.
Can you come back to,
Matt Daly, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
And I'll call on myself, Grace Lee, no conflicts, yes. So I believe we have, I'm calculating correctly, Dr. Cohn, 11 yeses, 0 nos, and the ayes have it, and the recommendation is adopted.
Yes, I have the same thing. The motion passes.
Terrific, thank you. And I will ask if individuals would like to comment about their vote or make any additional, have any additional clarification. So Dr. Talbot, I see your hand is.
Yeah, I just wanted to say how much I appreciated that ACIP and the work group and the CDC have really delineated the idea of a 3rd dose in a series for a primary series versus a booster. I think that's incredibly important. I think we're looking at a very specific population in the US that was not able to mount an appropriate immune response to the normal 2 doses. And so this is a very specific population and is not meant for the entire US population. We are all very worried about the Delta variant, but that may be the least of our problems if COVID-19 continues to circulate across the US and the world. And so I think it's incredibly important that we remember that we need to begin sharing more and more vaccines across the world and encouraging those pockets of low vaccination rates to immunize, or the Delta variant may be the least of our concerns. So just as a reminder, thank you.
Thank you. Dr. Paling, would you like to make a comment?
Yes, this is Kathy Paling. Can you hear me?
We can, thank you.
Okay, good. So thank you. I do want to express my sincere thanks to everybody at the ACIP, the working group, and the FDA for making this data available so we could have this vote. I voted yes for an additional dose of mRNA vaccine for all children and adults over 12 years of age with moderate and severe immunocompromising conditions to maximize their chance of protection from vaccine. These persons have increased risk of hospitalization, breakthrough disease, and death from COVID-19. In addition, the vaccine effectiveness among immunocompromised is lower than those without immunocompromising conditions. Recent studies demonstrate that 33 to 50% of persons with immunocompromising conditions who did not initially respond did respond with a third dose in the primary series. This vote enables all persons 12 and older to obtain a third dose in a primary care series to increase their protection from vaccine. It is critical to highlight persons with immunocompromising conditions and their families, the importance of wearing masks, maintaining social distance, and avoiding crowded locations indoors, and cocooning by having close contacts vaccinated. It's equally important to share and highlight the importance that all schools create plans so that all children, including those with moderate to severe immunocompromising conditions, can safely attend school. Thank you.
Thank you. Are there any other members who wish to state their opinion? Okay. With that, I'll just thank everybody for the vote and the robust discussion that happened today. And the committee will now recess for 4 minutes, so 55 after the hour, and we'll reconvene. Thank you.